Alright, hello everyone. Now we're starting with our next lecture, which is neurodevelopmental disorders, autism spectrum disorder. We'll be continuing with ASD today. Diagnostic criteria: persistent deficits in social communication and social interaction across multiple contexts, as manifested by the following currently or by history. Deficits in social emotional reciprocity, ranging from, for example, abnormal social support and failure of normal back and forth conversation, to reduced sharing of interests, emotions, or affect, to failure to initiate or respond to social interaction. Individuals with autism spectrum disorder are not able to emotionally connect in social situations, and they have a failure to respond to interests or initiate social interactions. Deficits in nonverbal communication behaviors used for social interaction, ranging, for example, from poorly integrated verbal and non-verbal communication to abnormalities in eye contact and body language, or deficits in understanding and use of gestures to a total lack of facial expression and non-verbal communications. Individuals who have autism spectrum disorder have difficulties in all of these things. For example, they cannot understand or use gestures, they lack acknowledgement or communication through expressions and non-verbal communications. There are deficits in developing, maintaining, and understanding relationships. There is difficulty in adjusting behavior to different social contexts, and there is also difficulty in making friends, and there's an absence of interest in peers. Severity is based upon communication impairment and restricted repetitive patterns of behavior. So that is what the severity is checked on: how frequent the behavior, if repetitive behavior is, how restricted communication is, how it is impaired. Restricted repetitive patterns of behavior, interests, or activities, as manifested by at least two of the following, currently or by history. There is stereotyped or repetitive motor movements or use of objects and speech. For example, simple motor stereotypes, lining up toys, flipping objects, or phrases. So these are very common. Insistence on sameness, inflexible adherence to routine or ritualized pattern of verbal or non-verbal behavior. Individuals with autism will have difficulty with transition. They'll have not rigid greeting rituals and rigid thinking patterns, and they need to take the same route or eat the same food every day. So there's consistency, and same they're the same things every day. Highly restricted fixated interests that are abnormal in intensity or focus. Their strong attachment to or preoccupation with unusual objects, excessively circumcised or preservative interest. Strong attachment to an object can be with anything. It can be a spoon, it can be something memorable a loved one may have given. Hyper or hyperactive to sensory input or unusual interest in sensory aspects of the environment. For example, there is indifference to pain or temperature, there is adverse response to specific sound or texture, excessive smelling or touching of objects, visual fascination with lights or movement. So there do come sensory limitations where sensory things do affect the individual. Severity is based on social communication impairments and restricted repetitive patterns of behavior. Symptoms must be persistent in the early developmental period but may not become fully manifest until the social demands exceed limited capacities or may be masked by learned strategies in later life. Symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. These disturbances are not better explained by intellectual disability, intellectual developmental disorder, or global developmental delay. Intellectual disability and autism often frequently co-occur to make comorbid diagnosis of autism spectrum disorder and intellectual disability. Social communication should be below that expected of the general developmental level. Individuals with a well-established DSM diagnosis of autism, Asperger's, or pervasive developmental disorder, not otherwise, should be given the diagnosis of autism spectrum disorder. Individuals who have marked deficit in social communication but whose symptoms have not otherwise met the criteria for autism spectrum disorder should be evaluated for social pragmatic communication disorder. Social pragmatic communication disorder is where an individual has difficulty in communicating in different social contexts in various situations. So that can be a different diagnosis, but it cannot be classified as ASD. The diagnosis can be specified if there is with or without accompanying intellectual impairment, with or without accompanying language impairment, associated with a known medical or genetic condition or environmental factor, associated with other neurological, mental, or behavior disorder, and catatonia. Recording procedures. For autism spectrum disorder, there that is associated with a known medical or genetic condition or environmental factor or with another neurodevelopmental, mental, or behavioral disorder, record autism spectrum disorder associated with the name of condition, disorder, or factor. Severity should be recorded at the level of support needed for each of the two psychopathological domains, for example, requiring very substantial support for deficits in social communication and requiring substantial support for restricted repetitive behaviors. We need to identify very clearly where the support is needed and how much is needed. Specification of with accompanying intellectual impairment or without accompanying intellectual impairment should be recorded next. Although an individual who has can have autism, but it is not necessary that they're not smart. Many individuals with autism are very smart. Language impairment specification should be recorded thereafter. If there is language, if there is any accompanying language impairment, the current level of verbal functioning should be recorded with accompanying language impairment, no intelligible speech, or with accompanying language impairment, phrase speech. If catatonia is present, we have to record it separately with catatonia associated with ESD. Specifiers. The severity specifiers may be used to describe succinctly the current symptomology which can fall below level 1 with the recognition that severity may vary by context and fluctuate over time. Severity of social communication difficulties and restricted repetitive behaviors should be separately rated. The descriptive severity categories should not be used to determine eligibility for and provision of services. These can be developed in an individual level and through discussion of personal priorities and targets. Regarding the specifier with or without accompanying intellectual impairment, understanding the often uneven intellectual profile of a child or adult with autism spectrum disorder is necessary for interpreting diagnostic features. Separate estimates of verbal and nonverbal skills are necessary, for example, using untimed nonverbal tests to assess potential strengths in individuals with limited language. Severity level for autism spectrum disorder. There are three levels of autism spectrum disorder that we will be studying. Level 3 is requiring very substantial support. In this level, the individual requires a large amount of support. There are severe deficits in verbal and nonverbal social communication skills, which cause severe impairments in functioning, very limited initiation of social interactions, and minimal response to social overtures from others. For example, a person with a few words of intelligible speech who rarely initiates interaction and when he or she does makes unusual approaches to meet needs only and responds to only very direct social approaches. There is inflexibility of behavior, extreme difficulty with coping with change, or other restricted or repetitive behaviors markedly interfere with functioning in all spheres. There is great stress and difficulty changing function, focus, or action. Level 2. In this level, the individual requires substantial support, not a lot of support, but some kind of support. In social communication, there are marked deficits in verbal and nonverbal social communication skills. Social impairments are apparent even with supports in place. Limited initiation of social interactions and reduced or abnormal responses to social overtures from others. For example, a person who speaks simple sentences, whose interaction is limited to narrow special interests, and who has markedly odd nonverbal communication. Restricted repetitive behaviors. There is an inflexibility of behavior, difficulty coping with change, or another restricted repetitive coping behavior. Behaviors appear frequently enough to be obvious to casual observer and interfere with functioning in a variety of contexts. There is distress or difficulty changing focus or level 1. Social communication. Without support in place, deficits in social communication cause noticeable impairments. There is difficulty initiating social interaction and clear examples of atypical or unsuccessful responses to social overtures of others. They may appear to have decreased interest in social interactions. For example, a person who is able to speak in full sentences and engages in communication, but whose to and fro conversations with others fails, and whose attempt to make friends are odd and typically unsuccessful. Restricted and repetitive behaviors. The inflexibility of behavior causes significant interference and functioning in one or more contexts. There's difficulty switching between activities. Problems of organization and planning hamper independence. To use the specifier with or without accompanying language impairment, the current level of verbal functioning should be assessed and described. Examples of specific descriptions for with accompanying language impairment might include no intelligible speech, nonverbal, single words only or phrase speech. Language level in individuals without accompanying language impairment might be further described by speaks in full sentences or has fluent speech. Since receptive language may lag behind expressive language and development in autism spectrum disorder, receptive and expressive language skills might be considered separately. Diagnostic features. The essential features of autism spectrum disorder are persistent impairment in reciprocal social communication and social interaction, which is criterion A, and restrictive and repetitive patterns of behavior, interests, or activities, which is criterion B. The Symptoms are present from early childhood and limit or impair everyday functioning, which is criteria C and D. The stage at which functioning impairment becomes obvious with vary according to characteristics of the individual and his or her environment. Core diagnostic features are evident in the developmental period, but intervention, compensation, and current supports may mask difficulties in at least some contexts. Manifestations of the disorder also vary greatly depending upon the severity of the autistic condition, developmental level, and chronological age, hence the term spectrum. Autism spectrum disorder encompasses disorders previously referred to as early infantile autism, childhood autism, Canadian autism, high functioning autism, atypical autism, pervasive developmental disorder, not otherwise specified childhood integrative disorder, and Asperger's disorder. The impairments in communication and social interaction specified in criterion A are pervasive and sustained. Diagnoses are most valid and reliable when based on multiple sources of information, including clinicians' observations, caregiver history, and when possible, self-report. Verbal and nonverbal deficits in social communication have varying manifestations depending on the individual's age, intellectual level, and language ability, as well as other factors such as treatment history and current support. Many individuals have language deficits ranging from complete lack of speech through language delays, poor comprehension of speech, echoed speech, or stilted and overly literal language. When formal language skills, for example vocabulary, grammar, are intact, the use of language for reciprocal social communication is impaired in the autism spectrum disorder. Deficits in social emotional reciprocity, which is the ability to engage others and share thoughts and feelings, are clearly evident in young children with the disorder. Children from a young age show symptoms that they are not able to indulge with other children and tell how they're feeling. They do not have a social emotional capacity, and there is little or no initiation of social interaction and no sharing of emotion, along with reduced or absent imitation of one's other's behavior. What language exists is often one-sided language lacking in social reciprocity and used to request or label rather than to comment, share behaviors, or converse. In adults without intellectual disabilities or language delays, deficits in social emotional reciprocity may be most apparent in difficulties processing and responding to complex social cues. Adults may have difficulty in social emotional cues because they may not know how to react in a situation, they do not know what to say, how to say it, and when to join a conversation, and what not to say. Adults who have developed compensation strategies for some social challenges still struggle in novel or unsupported situations and suffer from the effort and anxiety of consciously calculating what is socially intuitive for the most individuals. Deficits in nonverbal communicative behaviors used for social interactions are manifested by absent, reduced, or atypical use of eye contact relative to cultural norms. The eye contact can vary from one culture to another. Gestures, facial activity, expressions, body orientation, or speech intonation. For an early feature of autism spectrum disorder is impaired joint attention as manifested by a lack of pointing, showing, or bringing objects to share interest with others, or failure to follow someone's pointing or eye gaze. So these are an early features where an individual cannot meet with eye gaze, they cannot communicate properly, they do not take an interest in others, or they do not take interest in topics that are being discussed. Individuals may learn a few functional gestures, but their report repertoire is smaller than that of others, and they often fail to use expressive gestures spontaneously in communication. Among adults with fluent language and the difficulty in coordinating nonverbal communication with speech may give the impression of odd, wooden, or exaggerated body language during interactions. Individuals with autism cannot coordinate the body language, body gesture with words and speech that are being said. Impairment may be relatively subtle within individual modes. Someone may have relatively good eye contact when speaking, but noticeable in poor integration of eye contact, gesture, body posture, prosody, and facial expression for social communication. There are deficits in developing, maintaining, and understanding relationships should be judged against norms for age and gender and culture. There may be absent, reduced, or atypical social interest manifested by rejection by others, passivity, or inappropriate approaches that seem aggressive or disruptive. These difficulties are particularly evident in young children in whom there is often a lack of shared social play and imagination. For example, age appropriate, flexible pretend play, and later insistent on playing by very fixed rules. Older individuals may struggle to understand what behavior is considered appropriate in one situation but not another. For example, casual behavior during a job interview, or the difference between language that may be used to communicate, for example, irony, metaphors, sarcasm, or white lies. There may be an apparent preference for solitary activities or for interacting with much younger or older people. Frequently, there's a desire to establish friendships without a complete or realistic idea of what friendship entails. One sided friendships or friendships based solely on shared special interests. Relationships with siblings, co workers, and caregivers are also important to consider in terms of reciprocity. Autism spectrum disorder is also defined by restrictive repetitive patterns of behavior, interests, or activities which show a range of manifestations according to age and ability, intervention, and current supports. Stereotyped or repetitive behaviors include simple motor stereotypes, for example, hand flapping, finger flicking, repetitive use of objects, for example, spinning coins, lining up toys, and repetitive speech. Echolalia, the delayed or immediate parroting of heard words, use of you when referring to self, stereotyped use of words, phrases, or prosodic patterns. Excessive adherence to routine and restrictive patterns of behavior may be manifest in resistance to change, for example, distress at apparently small changes, such as in packing of a fair food, insistence of adherence to rules, rigidity of thinking, or ritualized patterns and behaviors of verbal and non-verbal behaviors, repetitive questioning, pacing a perimeter. Highly restricted fixated interests in autism spectrum disorder tend to be abnormal in intensity of focus. For example, a toddler strongly attached to a pan, a child preoccupied with vacuum cleaners, an adult spending hours writing out timetables. Some fascinations and routines may relate to an apparent hyperreactivity to sensory input manifested through extreme responses to specific sounds, or textured and excessive smelling or touching of objects, fascination with lights or spinning objects, and sometimes apparent indifference to heat, pain, or cold. Extreme reaction to or rituals involving taste, smell, texture, or appearance of food or excessive food. Restrictions are common and may be presenting features of autism spectrum disorder. Many adults with autism spectrum disorder without intellectual or language disabilities learn to suppress repetitive behavior in public. Special interests may be a source of pleasure and motivation and provide avenues for education and employment later in life. Diagnostic criteria may be met when restricted repetitive patterns of behaviors, interests, or activities were clearly present during childhood or at some time in the past, even if symptoms are no longer present. Criterion D requires that the features must cause clinically significant impairment in social, occupational, or other areas of current functioning. Criterion E specifies that the social communication deficits, although sometimes accompanied by intellectual disability, are not in line with the individual's developmental level. Impairments exceed difficulties expected on the basis of developmental level. Standardized behavioral diagnostic instruments with good psychometric properties, including caregiver interviews and questionnaires and clinical observations measures, are available and can improve reliability of diagnosis over time and across clinicians. Associated features supporting diagnosis. Many individuals with ESD also have intellectual impairment and or language impairment. They are slow to talk, their language comprehension is behind production. Even those with average or high intelligence have an uneven profile of abilities. The gap between adaptive and intellectual functional skills is often large. Motor deficits are often present, including odd gait, clumsiness, and other abnormal motor signs, for example, walking on tiptoes. Self injury, for example, banging head and biting the wrist, may occur, and disruptive, challenging behaviors are more common in children and adolescents with ASD than other disorders, including intellectual disability. Adolescents and adults with autism spectrum disorder are prone to anxiety and depression. Some individuals develop catatonic like motor behavior, for example, slowing and freezing mid action, but these are typically not of the magnitude of a catatonic episode. However, it is possible for individuals with autism spectrum disorder to experience a marked deterioration in motor symptoms and display a full catatonic episode with symptoms such as mutism, posturing, grimacing, and wavy flexibility. The risk period for comorbid catatonia appears to be greatest in the adolescents. Prevalence in recent years, reported frequencies for autism spectrum disorder across US and non-US countries have approached 1% of the population, with similar estimates in child and adult samples. It remains unclear whether high rates reflect an expansion of the diagnostic criteria of the DSM-4 to include subthreshold cases, increased awareness, differences in study methodology, or a true increase in the frequency of autism spectrum disorder. Development and course. The age and pattern of the onset should be noted for autism spectrum disorder. Symptoms are typically recognized during the second year of life, 12 to 24 months of age, but may be seen earlier than 12 months if developmental delays are severe, or noted later than 24 months if symptoms are more subtle. The pattern of onset description might include information about early developmental delays or any losses of social or language skills. In cases where skills have not been lost, parents or caregivers may give a history of a gradual and relatively rapid deterioration in social behaviors or language skills. Typically, this would occur between 12 and 24 months of age and is distinguished from the rare instances of developmental regression occurring after at least 2 years of developmental normal development, previously described as childhood disintegrative disorder. The first symptoms of autism spectrum disorder frequently involve delayed language development, often accompanied by lack of social interest or unusual social interaction, for example, pulling individuals by the hand without any attempt to look at them, or there will be patterns of odd play, for example, carrying things around but never playing with them, and unusual communication patterns, knowing the alphabet but not responding to their own name. Deafness may be suspected but is typically ruled out. During the second year, odd and repetitive behaviors and the absence of typical play become more apparent. Since many typically developing young children have strong preferences and enjoy repetition, for example, eating the same foods, watching the same video games multiple times, distinguished distinguishing restricted and repetitive behaviors that are diagnostic of ASD can be difficult in preschoolers. The clinical distinction is based on the type, frequency, and intensity of the behavior. For example, a child who daily lines up objects for hours and is very stressed if they are moved. Autism spectrum disorder is not a degenerative disorder, and it is typically for learning and compensation to continue throughout the life. Symptoms are often marked in early childhood and early school periods, with developmental gains typical in the later childhood in at least some areas, for example, increased interest in social interaction. A small proportion of individuals deteriorate behaviorally during adolescence, whereas most others improve. Only a minority of individuals with autism spectrum disorder live and work independently in adulthood. Those who do tend to have superior language intellectual abilities and are able to find a niche that matches their special interests and skills. In general, individuals with lower levels of impairment may be able to function independently. However, even these individuals may remain socially naive and vulnerable, have difficulties organizing practical demands without aid, and are prone to anxiety and depression. Many adults report using compensation strategies and coping mechanisms to mask their difficulties in public but suffer from the stress and effort of maintaining a socially acceptable facade. Scarcely anything known about old age in autism spectrum. Some individuals often come for the first diagnosis in adulthood, perhaps prompted by the diagnosis of autism in a child, in the family, or a breakdown of relations at work or home. Obtaining detailed developmental history in such cases may be difficult, and it is important to consider self reported difficulties. Where clinical observations suggest criteria are currently met, autistic spectrum disorder may be diagnosed provided there are no evidence of a good social and communication skills in childhood. For example, the report given by parents or other relatives that the individual had ordinary and sustained reciprocal friendship and good nonverbal communication skills throughout childhood would rule out a diagnosis of ASD. However, the absence of developmental information in itself should not do so. Manifestations of the social and communication impairments and restricted repetitive behaviors that define autism spectrum disorder are clear in the developmental period. In later life, intervention or compensation, as well as current supports, may mask these difficulties in at least some contexts. However, symptoms remain sufficient to cause current impairments in social, occupational, or other important areas of functioning. Risk and diagnostic factors. The best established prognostic factors for individual outcome within autism spectrum disorder are presence or absence of associated intellectual disability and language impairment. For example, the functional language by age 5 years is a good prognostic sign, and additional mental health problems. Epilepsy as a comorbid disorder is associated with greater intellectual disability and lower verbal ability. Environmental. A variety of non-specific risk factors such as advanced parental health, low birth weight, or fetal exposure to valproate may contribute to a risk of ASD. Genetic and physiological. Heritability estimates for ASD have ranged from 30% to higher than 90% based on twin concordance traits. Currently, as many as 15% of ASD appear to be associated with a known genetic mutation with difficulties, de novo copy numbers, variant, or de novo mutations in specific genes associated with the disorder in different families. However, not even when an autism spectrum disorder is associated with a known genetic mutation, it does not appear to be fully penetrant. Risk for the remainder cases appears to be polygenic and perhaps hundreds of genetic loci making relatively small contribution. Culture related diagnostic issues, since there are various cultures, different cultures, so each culture has a different teaching, different brought up, and different mindsets. Therefore, there can be cultural differences and a difference in how the culture is diagnosed. Cultural differences will exist in norms for social interaction, nonverbal communication, and relationships, but individuals with autism spectrum disorder are markedly impaired against the norms for their cultural context. Cultural and socio-economic factors may affect age at recognition or diagnosis. For example, in the US, late or underdiagnosis of autism spectrum disorder among African American children may occur. Gender related diagnostic issues. Autism spectrum disorder is diagnosed four times more often in males than in females. In clinical samples, females tend to be more likely to show accompanying intellectual disability, suggesting that girls without accompanying intellectual impairments or large delays may go unrecognized, perhaps because of the subtler manifestation of social and communication difficulties. Functional consequences of ASD. In young children with autism spectrum disorder, lack of social communication abilities may hamper learning, especially learning through social interaction or in settings with peers. In the home, insistence of routine and aversion to change, as well as sensory sensitivities, may interfere with eating and sleeping and make routine care extremely difficult. Adaptive skills are typically below measured IQ. Extreme difficulties in planning, organization, and coping with change negatively impact academic achievement even for students with above average intelligence. During adulthood, these individuals may have difficulties establishing independence because of continued rigidity and difficulty with novelty. Many individuals have autism spectrum disorder even without intellectual disability, have poor adult psychosocial functioning as indexed by measures such as independent living and gainful employment. Functional consequences in old age are unknown, but social isolation and communication problems are likely to have consequences for health in older adulthood. Differential diagnosis. Rett syndrome. Disruption of social interaction may be observed during the regressive phase of Rett syndrome. Thus, a substantial proportion of affected young girls may have a presentation that meets diagnostic criteria for ASD. However, after this period, most individuals with Rett syndrome improve their social communication skills, and autistic features are no longer a major area of concern. Consequently, ASD should be considered only when all diagnostic criteria are met. Selective mutism. In selective mutism, early development is not typically disturbed. The affected child usually exhibits appropriate communication skills in certain contexts and settings. Even in settings where the child is mute, social reciprocity is not impaired, nor are restricted or repetitive patterns of behavior are present. Language disorders and social pragmatic communication disorders. In some forms of language disorder, there may be problems of communication and some secondary social difficulties. However, specific language disorder is not usually associated with abnormal nonverbal communication nor with the presence of restricted repetitive patterns of behavior, interests, or activities. When an individual shows impairment in social communication and social interactions, but does not show restricted or repetitive behavior or interest. Criteria for social pragmatic communication disorder instead of ASD may be met. The diagnosis of autism spectrum disorder supersedes that of social pragmatic communication disorder whenever the criteria for ASD are met, and care should be taken to inquire carefully regarding the past or current restricted or repetitive behavior. Intellectual disability without autism spectrum disorder. Intellectual disability without ASD may be difficult to differentiate from ASD in very young children. Individuals with intellectual disability who have not developed language or symbolic skills also present a challenge for differential diagnosis since repetitive behavior often occurs in such individuals as well. A diagnosis of ASD in an individual with intellectual disability is appropriate when social communication and interaction are significantly impaired relative to the developmental level of the individual's nonverbal skills. For example, fine motor skills, nonverbal problem solving. In contrast, intellectual disability is the appropriate diagnosis where there is no apparent discrepancy between the level of social communication skills and other intellectual skills. Stereotypical movement disorder. More stereotypies are among the diagnostic criteria of ASD, so an additional diagnosis of stereotypic movement disorder is not given when repetitive behaviors are better explained by the presence of ASD. However, when stereotypies cause self injury and become a focus of treatment, both diagnoses may be appropriate. ADHD abnormalities of attention are common in individuals with ASD, as is hyperactivity. A diagnosis of autism spectrum disorder or attention deficit hyperactive disorder should be considered when attentional difficulties or hyperactivity exceeds the typically seen in individuals of comparable mental age. Schizophrenia. When schizophrenia with childhood onset usually develops after a period of normal or near normal development. A prodromal state that has been described in which social impairments and atypical interests and beliefs occur, which should be confused with the social deficit seen in autism spectrum disorder. Hallucinations and delusions, which are defining forms of schizophrenia, are not features of ASD. However, clinicians must take into account the potential for individuals with ASD to be concrete in their interpretation regarding the key features of schizophrenia. Comorbidity. Autism spectrum disorder is frequently associated with intellectual impairment and structural language disorder, which should be noted under the relevant specifiers when applicable. Many individuals with autism spectrum disorder have psychiatric symptoms that do not form part of the diagnostic criteria for the disorder. When criteria for both ADHD and ASD are met, both diagnoses should be given. The same principle applies to concurrent diagnosis of ASD and developmental coordination disorder, anxiety disorders, depressive disorders, and other comorbid diagnoses. Among individuals who are nonverbal and have language deficits, observable signs such as changes in sleep or eating and increases in challenging behavior should trigger an evaluation of anxiety or depression. Specific learning difficulties are common as is developmental coordination disorder. Medical conditions associated with ASD should be noted under the associated with the known medical, genetic, or environmental acquired condition specifier. Such medical conditions include epilepsy, sleep problems, constipation. Avoid restrictive food intake disorder is a fairly frequent presenting feature of autism spectrum disorder, and extreme and narrow food preferences may persist. So that was all for this topic of autism spectrum disorder. I will see you in the next class. Take care.